Okay, good morning, everybody. I think we're going to get started. I'm Ann Wong. Dr. James Paul cannot be here this morning, so I have the honors of introducing our speaker today. So it gives me great pleasure to introduce to you Dr. Scott Beattie and welcome him back to McMaster University. So he's going to be presenting on anesthesia incident reporting and safe surgery, but I'll give you a little bit of background about Dr. Beattie. So Dr. Beattie completed his Bachelor of Science from the University of Waterloo, and then subsequently a PhD from McMaster University, and then subsequently his MD and anesthesia residency at McMaster University. He held a faculty position in the Department of Anesthesia at McMaster University from 1986 to 2000 before joining the Department of Anesthesia and Pain Management at the Toronto General Hospital at the University Health Network. At that site, he held the R. Fraser Elliott Chair in Cardiac Anesthesia from 2004 to 2019. Dr. Beattie is currently a professor in the Department of Anesthesia, University of Toronto Faculty of Medicine, and he is the medical director of the Canadian Anesthesia Incident Reporting System. He's authored or co-authored over 200 peer-reviewed publications, and he holds numerous research grants and has really been very, very prolific scholar in this area. His interests include perioperative outcomes research, cardiovascular research, research methodology, and golf. So without further ado, I want to welcome Dr. Scott Beattie.
Well, thank you very much. I'm having a bit of deja vu. The only difference is there used to be carpet here in this room. Anyway, thank you for inviting me. I'm here to sell the idea that incident reporting is a good idea. And I have a little bit of administrative work to do. Apparently, you have to put this code in to get your attendance counted for your single point of CME. So this is the code. I'll leave that up for a minute so you can't miss that. So what I want to do today, I want to talk a little bit about anesthesia incident reporting, which is going to be referred to as an AIRS system. I'm going to talk briefly about barriers to reporting incidents. I'm going to talk a little bit about the utility of outcome data through incident reporting. And I want to talk to you a little bit about the future direction of CARES, which is the Canadian Anesthesia Incident Reporting System. So right before I start, I want you to get out your phones and I want you to log into this website. This shows the CARES data software capture system. So it's software that's been developed over the last few years, and it's designed to collect data specifically for anesthesia incident reporting. It is this website is specific to McMaster University, so everyone in McMaster can utilize this, and you can start utilizing this today if you want. The data is all McMaster. It won't be shared with anyone. And it can be utilized only by McMaster. And I will give whoever is your M&M person specific instructions on how to download the data once it's in there. What I really want to talk to you about is trying to increase the usage of the incident reporting system. Because basically, I'm here today as a salesman. I'm here to promote the idea that AIRS is the bedrock of anesthesia safety. And I think that CARES is a tool that I think if you use will facilitate reporting of any events. Underreporting of events is a huge problem. And it's recognized worldwide as as, as an impediment to future patient safety. Now, George Santayana said, those who cannot remember the past are condemned to repeat it, which is the idea that I'm trying to get across, is that it's only by recording our problems that we actually can figure out what they are and how to move forward. And anesthesia typically has focused on the most devastating of the incidents, and it's through that process that we've identified lots of things that we have to work on in the future. The first example of that I know of is a report by Beecher and Todd in the Annals of Surgery in 1954. Beecher and Todd were surgeons, and they actually surveyed 10 hospitals over a 4-year period, and they reviewed almost 8,000 deaths in 600,000 specific and separate surgeries over 4 years at 10 hospitals in and around the New England area. They looked at each one of those 8,000 deaths, and they looked at the primary cause in that, and they determined that they had a 1 in 75 chance of dying due to surgery. And the chance that that was related to an anesthesia incidence was 1 in 1,500. So that's a little devastating, but more importantly, what they identified is that if you were using curare in 1948 to 52, it increased the incidence of mortality 6-fold. And that finding is the impetus for improving the design of endotracheal tubes, changing the way we ventilate, positive pressure ventilation in the OR, which didn't exist before that period of time, and anesthesia, neuromuscular blocking, monitoring, all things that we take for granted today. There's a brief history of anesthesia incident reporting, and I'm going to start with Jeffrey Cooper. Jeffrey Cooper is the founder of the Anesthesia Patient Safety Foundation, and in 1976 conducted interviews on over 100 anesthesiologists about incidents that had happened in their practice. And he determined at that point that 80% of those were preventable. It's this research that led for the Canadian Anesthesia Society guidelines to call for, in the practice of anesthesia, a quote, it's to each anesthesia department should employ a systematic approach for monitoring the quality of anesthetic care provided by members of the departments of anesthesia throughout a healthcare facility. That is a fiduciary responsibility of each department head. And there's been a couple of examples of that on paper. In 2006, the Australia-New Zealand College of Anaesthetists convened a committee, and they've formed a patient safety group in Australia, New Zealand, with the sole purpose to provide an electronic platform to collect anesthesia incident reporting. And they launched WebAIRS in 2009. About the same time, the American Society of Anesthesiologists held a forum where they invited everyone from around the world to convene and talk about incident reporting. And I was invited to that meeting. And at that meeting, WebAIRS presented their platform. And that was the impetus. And if you look at the Anesthesia Quality Institute, AQI, which is the American Anesthesiologist Society's website, you'll see that the website, the data collection is exactly the same. So they're collecting the same type of data. And over a period of years, through the CAS, Susan O'Leary was one of the presidents at the time of this, the Canadian Anesthesia Society came to an agreement with the Australia-New Zealand group, and we utilized their software to create the Canadian Anesthesia Incident Reporting System, which was launched in 2018. There's other types of anesthesia reporting, and the most prominent of those are the national audits being conducted by the Royal College of Anaesthetists of Great Britain. And they have, every year they put out a national audit program. The most recent is NAP6, which I'll talk about in a little bit. So if you ever read The Field of Dreams, you'll know that W.P. Kinsella said, if you build it, they will come. So the CAS Board of Directors endorsed the creation of a Canadian anesthesia reporting system in 2016. We used the New Zealand data and created a separate set of software, and it was based on the information collected exactly the same as the Australia and New Zealand. But we had some requirements that were a little different than theirs. The software we've created is available on all platforms. You can get it on your phone, you can get it on your tablet, you can get it on iOS, you can get it on Android, you can have it on your desktop. So it's available wherever you can get a web signal. We launched it in the late 2017, and it was available to all Canadian Anesthesia Society members, which the way we launched it has turned out to be a bit of a mistake. Well, it's a huge mistake. We, with the launch, we did a blitz trying to create some notoriety for the system. That included an editorial which was published in the Canadian Journal. We presented the website for 6 months prior to launch. We highlighted it at 2 national Canadian anesthesia annual meetings. And we thought this would be the way to go ahead. This is the screenshot of the editorial that was published in the Canadian Journal. And in that, we highlighted the World Health Organization's draft guidelines to create adverse events reporting. And it had a checklist on it, a checklist of the types of things that had to go into an incident reporting system. The data input had to be voluntary, it had to be confidential and non-punitive. Data collection had to be very easy and clear. And as you go through the website, I think you'll find that we've done that. There has to be a way to analyze the data that has to have a classification of events, and it has to be done by experts, and then the data has to be fed back to the users. In the editorial, we also included a list of the types of things the types of incidents that we suggested which should be collected. And it's a long and extensive list, and I'll go through that in a little bit. We also conducted a survey. We announced this on the CAS website. We had two email blitzes where every member of the Canadian Anesthesia Society received a notification that there was a survey ongoing, and this was available online. However, the response was less than, well, it was abysmal. 7% of the membership of the CAS responded to this. So if you have 140 responses out of 2,000 members. So we don't know why that is, but it's really a poor response. More importantly, we've been now operational for 19 months, and we have 67 reported incidents in the 19 months. If you compare that to ANSCA or WebERRS, today on WebERRS they have 7,640 responses. It's been operational for 10 years, so they're getting 740 responses every year. We're getting 70 a year, so 1/10 of the response rate. So obviously this is a very poor response rate, and we're trying to figure out the reasons for that. Now we have several ideas. One is that there is a lack of a culture of safety in Canada, which I don't believe for a second. So the other thing to focus on is what are the barriers to reporting. There are basically 4 easy ways to look at the incidence reporting. One of the most obvious is it's time consuming, and it's just another thing that you have to do, another piece of paperwork that you have to do, and that's what happens all the time. Every time you turn around, you're being asked to fill out another piece of paper. The second is a fear of reprisal. People are afraid they're going to be sued, or they're going to have to put up with the ridicule of the rest of their department, which is a major, major problem. People don't know what to report. They don't know what is an incident, what isn't an incident. And there's a fear that they're just putting data into a black box and they're never going to have anything come back from it. So is it time consuming? CARES is quick and easy to use. As you see now, you can just, if you have it on your phone, you can go through it very quickly. It takes about 5 minutes to put in an event. It's accessible on every electronic platform. However, part of the problem with the way we launched it is we required dual authentication, which means we had to make sure it was restricted only to Canadian Anesthesia Society members, and you had to remember your ID number to log in, and then you had to wait for a secondary email to come back. We did this for secure reasons. We didn't want to get reporting from people who weren't anesthetists or weren't members of the Canadian Anesthesia Society. That's probably one of the biggest reasons we haven't got a lot of response. It does, however, capture just about every type of anesthesia incident. It can capture incidents in the preoperative assessment time period. It can intraoperatively and postoperatively, and it can actually capture incidents for chronic pain use. Fear of reprisal. There's several areas that have to be discussed here. First of all, it's private. The website complies with all aspects of both Canadian national and provincial privacy laws. It has the ability to be anonymous, and it is not discoverable. The data is secure. You don't have to worry about it being hacked. It's behind a double firewall. There's dual authentication required. So it's a very secure system, but that's part of the problem. People don't know what to report. What is an error? There's a difference between an adverse event and an error. An adverse event is defined as a patient not responding optimally to an appropriate treatment. And it can be a side effect or an expected complication or desired complication or something that happens unintentionally, but it's still something that was not preventable. An error is an adverse event that could have been prevented given the current state of medical knowledge. We want to collect in CARES not only errors, but also infrequent events. So what should I report? Well, errors, there's drug errors. There's a variety of different types of drug errors. Wrong drug, wrong dose, wrong route, a drug swap. You have 15 syringes on your back table. You turn around, you grab the wrong one. That's an error. It happens occasionally. It happens more frequently than you want to talk about. The other one is missing a dose. How often do you give antibiotics up front and then forget to redose at 4 hours? Those are all errors. Other errors are things like prepping the wrong side, performing a block on the wrong side, performing surgery on the wrong side, and transfusion-related problems. Rare events are things such as anaphylaxis, aspiration, cardiac arrest, malignant hyperthermia, fires, residual paralysis, for instance, and awareness. All of those can and should be reported. One of the biggest areas that we should be talking about is breaks in processes of care. How often do you miss the surgical checklist? How long is it? How many times is it done properly? How often is the surgical checklist done with the surgeon, the primary surgeon in the room? How often are antibiotics given prior to incision? How far in advance? Giving them just before the incision isn't appropriate. How often do you forget your antibiotic redose? How often do you not use DVT prophylaxis, and why? One of the big problems right now is drug shortages. How often do you have to switch the drugs you prefer to use? Equipment failures and malfunctions or inavailability. For instance, how often do you have a working neuromuscular monitor in the room? How often does that lead to a problem? And things like anemia. Is there some sort of protocol in your hospital to deal with anemia properly? Hypotension, hypothermia, and hypoxia. All are things that we try to avoid. When they happen, we should probably record them. One of the biggest problems that we have identified, however, is as a lack of feedback. I've been to several places around Canada and talked to the quality directors in different institutions, and the overriding fear is that people are going to put their data into a national database and not have it for their own use back in their own hospitals. And that's actually been an impediment in 3 or 4 different institutions. So they're afraid that the data that goes into the national database is not available for their own use. So that's one of the reasons that we've restructured CARES so that it functions at a local level. So our first plan is to institute it at different university centers, and we have created a website for every university department in the nation. The overriding purpose, right from the beginning of CARES, was that the feedback would be delivered to everyone to change care. And this has been done by the anesthesia incident reporting systems that exist currently. These are websites for web errors, and I encourage you to log into these. AQI, which is the ASA's Anesthesia Quality Institute, and the Royal College of Great Britain, where they have a website that publishes all of their national audits. This is feedback that's available right away. Here's an example of what's available if you enter data into a website. This is for anaphylaxis. This is from the WebAir system. 205 cases of anaphylaxis in their first 7,000. Actually, this is after 4,000 cases downloaded into their incident reporting system. Some very interesting things here is that the first inciting or the first sign of an anaphylactic reaction is hypotension almost all the time, and it usually occurs within 10 minutes of the induction of anesthesia. And most people initiate a treatment for the hypotension before they understand that it's an anaphylactoid reaction or an anaphylaxis reaction. There is also some suggestions here on how to treat refractory hypertension and refractory bronchospasm. And you can see that the 10% of these people have severe and lasting harm, defined as an inability or a prolonged a prolonged period of disability post the event. 3 of the events were fatal. I'm going to show you the National Audit Program from the Royal College, which also has just finished an analysis of anaphylaxis. And this is an infographic. This is a really good example of how you can convey data back to people as soon as you have the answer. This is available on their website. It can be downloaded very easily, and it is it's an overview of everything that was found in the audit program. This audit included 100% of the hospitals in the National Health Service in Great Britain. The incidence of perioperative anaphylaxis was 1 in 10,000. Now they had 196 episodes in this audit, but over 100 of these of their cases they couldn't confirm were anaphylaxis, and they didn't include them in their analysis. So in fact, probably the incidence of anaphylaxis is higher than the 1 in 10,000. It's probably more like 1 in 7,000. The number one reason that people have an anaphylactic reaction is related to an antibiotic. In second place are the muscular blockers, and succinylcholine is twice as often the culprit as the non-depolarizers, followed by chlorhexidine and dye. Interestingly enough, they found no episodes of anaphylaxis to latex in this audit. Again, they confirmed their findings in the WebERRS finding that the lowest, that hypotension was the lowest. Hypotension was the presenting factor in just about every case. And 15% of the people who had 15% of the people had cardiac arrest, and that was related to hypotension. One of the recommendations that came out of this audit was the fact that if you get a blood pressure of under 60 systolic, that you're having trouble resuscitating, as they suggest you start CPR immediately in that situation. They found that the causes, the associations with death were in people who were elderly and obese. And the interesting thing is they found that one of the antibiotics that caused anaphylaxis was people who had a supposed penicillin allergy, and they switched their plan to a secondary antibiotic to avoid penicillin. And that was a 17-fold increase in the anaphylaxis when that happened. The final things is a third of patients experienced prolonged harm. So this is probably the 2 largest data sets on anaphylaxis, and it's readily available, and you can be put on a website, or it can be downloaded to your phone, to your tablet, to your desktop in the OR if you need it. So what are we doing with CARES to try and improve its acceptability and its usage across Canada? We're trying to attack those 4 barriers. I want to assure you that we think that this is best done, and all of the models around the world suggest that it works best at the local level. That's one of the reasons that we've created a local website, or a local website for each of the university departments. We're not limiting it to community hospitals, but we only have so many resources, and we have to start somewhere. So our plan is to create a network of websites. So we're going to have McMaster University, for instance, and it's set up this way because I'm here. McMaster will have a website. It's for your own use. It can be accessed at any time by your QI directors. But the data flows to a national website. We currently have the the software in the University of British Columbia, the University of Manitoba, McMaster, University of Toronto, which is my institution. We have Queen's, McGill, and Memorial University. We can set it up for any system, anywhere. We can set it up for GP anesthetists in local hospitals. And residents could use this as a log for their competency by design. One of the things in CanMeds is that residents have to keep a log of their safety activities. We were proposing that they could use this as a website, or use this website as a log as well. And then eventually we'll have all medical schools in Canada producing data and putting it into the website. The other area that we're looking at, and this is something that the Oversight Committee for CARES is looking at right now, is proposing a prospective cohort study. The objective of this is to look at the errors in process of care and infrequent events, and how often does that impact a patient outcome. For instance, what's the incidence of perioperative errors in Canada? Nobody has any idea what the denominator is. How often do these errors lead to an adverse event? What proportion of adverse events account for these errors count for adverse events? The design would be to set up in every university center and to use the CARES data set, the CARES website and the data, or the software as an electronic case report form. The sample size would have to be fairly large to capture this. An example of such a cohort was the Apricot study, was published in Lancet 2 years ago, which looked at 30,000 patients in pediatric anesthesia, and the incidence of errors in that study was 5%, 5 per 100. We're proposing that we do a study like that, and we would require about 30,000 patients. Now, we do have some experience running cohorts of that size, and we think that we'd need 80 hospitals doing a 14-day cohort study that would collect 30,000 events, or 30,000 patients, and would give us around 1,500 events to analyze. We do have some experience of that. We did run ISA, the International Surgical Outcomes trial, which we ran in Canada, was one of the sites, and we collected in a 7-day cohort study of elective patients, 44,000 patients. I want to give you some final food for thought. This is a map of the world that we used in ISOS. Okay? ISOS was a 7-day cohort study that collected data on only elective surgery in 27 countries and 325 hospitals. In the 7 days, we collected data from 44,000 patients, 19 high-income and 9 low-medium-income countries. 17% of people had a postoperative complication. So like 1 in 5 patients had a complication after surgery. And of those, 10%, 1 in 10, had a moderate to severe complication. 1 in 10. Mortality at 30 days in hospital, so these are only people who stayed in hospital, was 0.5%. When you look at the outcomes, it didn't matter whether you were from a high-income or a low-income country. If you're in a low-income country, you don't tend to be as sick when you have your operations. Not as many ASA 3s and 4s. They tend to be younger, and the complication rate is 11%. High-income countries are older, sicker, but the complication rate is 20%. When you adjust that statistically, there's no difference in the rate of complications, whether they're high incidence or not. So across the world, high-income countries, including Canada, the United States, and Great Britain, the incidence of adverse events is serious adverse events is about 10%. We have conducted many studies. We've looked at prospective studies where we've looked at reducing cardiac complications. We've looked at the types of anesthetics, Enigma 2, for instance. We've looked at fluid therapy. None of them have made any difference to our outcomes. I'm going to suggest to you that a lot of what we're looking at in that complication rate are errors or breaks in processes of care. And until we conduct a study and until we collect data, we're not going to be able to improve those outcomes, which are very much in need of improvement. And I think with that, I thank you very much for your attention, and I'll take questions.
Thank you very much, Dr. Beatty. It's really my pleasure to see you here today, having been involved with the start of this project. I'm going to speak here, and then you need to speak here to answer the questions. So first of all, I'm filling in for Dr. Wong. She had to leave. And I'm Susan O'Leary for the people who are not in the room. And Dr. Wong asked me to tell you that there's actually hot food up here in front of the room that she forgot to announce earlier in the morning before I forget to do the same thing. So to start, I'll open the floor to questions. I do have to repeat the question into the microphone, and then Dr. Beatty can answer the questions. Any questions from the floor? Chris?
It's not an in-charge presentation. I use the Mainport app all the time, so I keep track just as I go along. Is there any hope of an app for this? You just report it quickly on your phone?
So Dr. Ricci is saying he uses the Mainport app, or you use the link on your phone, I think is what you're saying. The app on the phone, and your question is
I'd like an
an
app for this.
app for the CARES.
So I don't have to go to the computer, look up the log or everything else, and make life easy for myself.
You can download the website directly onto your phone and just touch it, and you still have to put in your password, but you can just download the website directly onto your phone. You don't need an app for it because this is functional across any type of platform. Just put it on your screen.
There is an option for save password. I did it, so you don't have to remember your password.
Yeah. Don't recommend that.
It works. Jeff.
The incident reporting systems that have a much higher rate of reporting, like in Australia, New Zealand, and the UK, are they limited to anesthesiologists registering those incidents, or are other people in the care team reporting like nurses?
So briefly, the question is, in other countries who use this, is the reporting limited to anesthesiologists?
In Australia, it can be anybody providing anesthesia care. It could be an anesthesia assistant, it could be a resident, it could be a fellow, or a staff person. We did make a big mistake when we started and limited to just CAS members. So that's basically one of our major mistakes right off the bat. And we hope that the reason I'm here is to try to rectify that, as soon as possible.
Dr. Reddy.
Thanks for you succeeded in getting us to buy in, but that seems to be a problem nationally. Obviously, buy-in has been limited as well. So I'm just wondering whether you think the net is too broad, and maybe you should limit it to a few incidences and make that a mandatory reporting system.
So Scott, you could probably answer the question, and
Okay.
people understand.
So the question is are we trying to do too much, basically, and if we cast a smaller net and just limit it to a couple of subjects, would we have greater success? I think that's the philosophy behind the national audit programs in Great Britain. And I think they both produce very valuable information. The problem is you don't know what you're looking for. So, for instance, In Australia and New Zealand, one of the very interesting things they found was that because of their NPO guidelines, they suggested that people chew gum. They now have something like 57 incidents where people have not spit out their gum, and it's been found. And in fact, they have 2 cases of aspiration of chewing gum. So a national audit's not going to pick that up, but this type of thing will pick that kind of thing up. So there's things happening that we don't know about, and casting a wider net is going to do that. What we need is people to buy into the philosophy that you have to report everything, and without fear of reprisal. So we've looked at the security and also the discoverability of this. We had the CMPA conduct an analysis of whether this was discoverable. I have asked the opinion of a retired Supreme Court justice on whether this is discoverable. I've asked lawyers for plaintiffs what they would do if they knew that this existed. The long and the short of it is, if you use it at a local level and you use it here as your quality improvement, part of your quality improvement, it is not discoverable. It's not discoverable because it is a patient, you're deemed to be a patient safety organization. The Supreme Court justice said there's no way that this is going to, at an appeal, this is going to be released if you're conducting it at a local level. And the plaintiffs have said, the plaintiff lawyers have all said, when we know that this exists, we're going to try and go after it. But the chances that we're going to get it is about 0. So as long as you're safe from that type of reprisal, having to deal with your colleagues, is a different thing. Now, the former chair of this department and I went through medical school together and residency together. And at the end of medical school, the esteemed Dr. Buckley created something called the SIBS manual. SIBS stands for the Sudden Intake of Breath Syndrome. And that's from when you tell one clerk talking to another clerk what you did in the OR, you did what? And that's the type of thing that I don't think is a big problem. Okay, you do stupid stuff. I mean, I did lots of stupid stuff. So Dr. Ritke can attest to that, because I was a resident with him. Anyway, I hope that answers your question.
Actually, I have one question. So if we use our McMaster data, is there a way we then can compare the same incident, say difficult airway, with a national norm that CARES will give us?
Yeah, absolutely. Because if you have your own data, and you also have access to the national data, so you can do that anytime. You can benchmark. You can do any of that as long as you have an idea. There is some oversight for the data at the national level. So if you want to use the data, you have to go to the committee and ask them and tell them what you're doing, and you have to have a protocol. That's all part of good clinical practice and good research methodology. But as long as you have a protocol, there's no way they're going to turn you down. Yeah.
Thanks. We have a new quality person in our department, and I'll connect you with her, but she'll for sure have some questions for you as well. Thomas?
Absolutely. Well,
Do you want to take that?
no.
Maybe I will.
You're better to answer that one.
So in the development of this system, there was much and prolonged debate about who would be able to access it. And the initial thinking and plan was that it would be a member benefit, because we are trying to create benefits for people who pay their dues for the Canadian Anesthesia Society and become members. So part of the initial rollout was to say, here's a benefit for you, come and join our society. I'm not on the executive anymore, and I'm not on the board, so I'm not party to those discussions, but it certainly sounds like that thinking has changed a little bit. So this system is now available for non-members, correct? So anyone in our department or any Canadian anesthesiologist can now enter data into the system. To use that data, it's still my understanding that you would need to be a member. So if we decided we want to pull data and do a project, we would need an Anesthesia Society member to lead that and get that data out. I think, personally, I think that this was a good decision to allow anyone to access and put information into the system, because we really need a very broad gathering of information across the country. Are you okay with that, Scott?
Yeah. So, like everything else, the problem is money. And basically, this was run on a shoestring budget, and it's still run on a shoestring budget. And one of the reasons that we're going to go ahead with a cohort study is that we think that we can get, we can make a really good case for CIHR funding to conduct the cohort study. And we think we can get enough money to run it for 6 or 7 years through the CIHR if we do the cohort study appropriately. And there's lots of people involved at the national level who have experience with CIHR funding. And they're all involved in the planning of this cohort study. So that's going to alleviate some of the funding problems for now anyway. But it still requires a budget, an ongoing budget, and it's going to cost about $150,000 a year to run this properly. But there's a variety of things that you can do once you have data. And our vision is to have the feedback available to the website just by clicking on it. We've created an electronic data, a name system for our anesthesia department, which is totally electronic, and it's from pre-op to post-op. And one of the screens on that asks the question, was there an incident? And as soon as you click that, it downloads all of the relevant data into the CARE system. And that's our vision for the future, but that costs money. And that's where we're trying to go.
Thanks. Any other questions, comments? Anything to wrap up? Well, I'd like to thank everybody for coming this morning. For HHS, you'll find that the link or the link to the CARES website will be embedded as a permanent link in our newsletter as well as on our website. And I'll be connecting our quality people with Scott so we can really work on getting this moving and use it for our own benefit. So I'd like to thank you very much for coming in this morning.
Okay, thanks.
Thank you all.